A 65-year-old diabetic male with a history of hypertension, blood pressure 150/90, hyperlipidemia, and ongoing alcohol use, 4 drinks a day for 3 years, presents with new onset dyspnea on exertion and lower extremity edema. His ejection fraction is 40%. What is the most likely etiology of his heart failure? 1, toxin, alcohol-induced, 2, ischemic, 3, endocrine, or 4, hypertensive. So a good mix of answers there. And I think that this is a tough case because he has some different things. Each of these could be contributors. If we play the odds, the most common cause of systolic heart failure is that of ischemic heart disease. And if you look, he has risk factors of diabetes, hyperlipidemia, hypertension, and a more advanced age. And so when we're looking at this, the most likely cause of his heart failure is that of ischemic disease. And it's important to recognize that because this is a reversible cause. Right? If we improve the perfusion to the myocardium, we can restore left ventricular systolic function. How about toxins? How much alcohol is needed to cause an alcoholic cardiomyopathy? So 7 drinks a day for 5+ years. So if you're seeing someone who has a drink or 2 a night, that's generally not going to be an alcohol-induced cardiomyopathy. There can be infectious causes, influenza, Coxsackie, peripartum cardiomyopathy if this is occurring in the last month of pregnancy or the first 5 months thereafter, inflammatory causes, endocrine-mediated, including hemochromatosis identified by an iron to total iron binding capacity ratio of greater than 50%. Stress-induced cardiomyopathy is a condition that we're recognizing more and more. It's also called Takotsubo cardiomyopathy, named after the octopus catching pots that the left ventricle resembles on a left ventriculogram. Tachycardia-induced cardiomyopathy can occur either in the setting of frequent ventricular ectopy, generally when there's 15,000 PVCs or more, or when there's been uncontrolled atrial fibrillation rate. Or long-standing chronic systemic hypertension, placing a heavy afterload on the ventricle can cause it to wear out. Infiltrative disease is less common, but it's one that you don't want to miss. Here we see a patient who has an enlarged tongue. This would make us think about amyloidosis. But even with all this differential, we're not always that good at finding it. We can go down and cross the T's and dot the I's, but still sometimes we're left with idiopathic dilated cardiomyopathy. And that's really a diagnosis of exclusion, but it's something that's not infrequent. It can be a little bit frustrating for the patient because we don't know the underlying cause, but we still can treat it with guideline-directed medical therapies.